everyone. Welcome to the University of Washington Division of Rheumatology Grand Rounds. A couple of reminders before we start. The session is currently being recorded and it will be posted later on our website. There will be a Q&A session at the end, so please add your questions in the Q&A feature and not in the chat box so that it's easier to moderate. And now I'll let Dr. Gardner introduce our speaker for today.
It's my great pleasure to introduce Elizabeth Ferucci. She is one of our affiliate professors in the Division of Rheumatology and has been a member of the faculty for many years, headquartered in Anchorage, Alaska. Elizabeth did her undergraduate at Columbia, did her medical school at NYU, her residency in internal medicine and fellowship in rheumatology at the University of Colorado. Along the way, she got an MPH at Johns Hopkins and also a certificate in clinical research at the University of Colorado. Since 2004, Elizabeth has been on the staff of the Alaska Native Medical Center in Anchorage and the Southeast Alaska Health Consortium and numerous hospitals in Alaska. I was impressed with how many hospitals she actually is credentialed to work at. Elizabeth is an active researcher, and she's one of the premier, if not the premier, researcher in what she's going to talk to us about. She has several large grants dealing with health disparities as well as epidemiology in Native Alaska population. And she and I participated several years ago in a symposium at the ACR on Native American, Native Alaskan issues. She's also an excellent educator and regularly hosts students, residents, and hosted one of our fellows, Joanna Marco, several years ago. And Joanna just enjoyed her time with Elizabeth so much. So with that, I'll turn the time over to Elizabeth and look forward to what she's going to teach us today.
Good morning. Thank you so much for the kind introduction. And as Dr. Gardner mentioned, I've been working up in Alaska for almost 20 years and part of the WWAMI region, of course, in that work. And the talk I'll give today will just sort of cover some of the highlights of both research and clinical care related to this work with the Alaska Native population here. I'm just hoping it'll spark an interest in, future and continued collaborations and other ideas that you have about how we can improve clinical care and outcomes for American Indian and Alaska Native people with rheumatic disease. I'd like to begin by acknowledging the Dena'ina people on whose traditional lands I live and work in Anchorage, Alaska. I'm grateful for the Dena'ina's past and present stewardship of this place. In addition, I'd like to acknowledge other Alaska Native people in other parts of the state who've been stewards of this beautiful place for more than 10,000 years. Dr. Gardner gave kind of a traditional academic introduction, and I'll just give you a brief self-introduction that deviates a little bit from that. I just do this to be clear about who I am and how I came to Alaska, and maybe inspire others to pursue sort of non-traditional career paths. So I grew up in Baltimore, Maryland. I'm not from Alaska. I'm not an American Indian or Alaska Native person. In the upper left is my parents at my medical school graduation. I went to college and medical school in New York, as you heard. My father is first generation Armenian American and my mom's European American. In the middle picture on the top, when I was in Colorado, I met my husband and he was from Alaska and really wanted to come back. And so the middle picture is kind of our journey up here with our 1-year-old daughter up the Alaska Highway, which we drove in 10 days from Denver. In the upper right is sort of a more recent picture of my family, including my husband and 2 kids at my daughter's drive-by 2020 graduation from high school. And then in Alaska, I kind of, as you heard, I sought out an academic type career in a place where there really isn't a local academic medical center, of course. So you are the closest one, and it's about 1,500-mile flight from Anchorage to Seattle. And this has been a really rewarding career path, although different and sometimes challenging. And I'm showing the pictures on the bottom of kind of how we get places and how the travel can be difficult. On the bottom left is a float plane that we take to one of the places in Southeast Alaska. And then on the bottom right is just me sitting in front of a computer showing you how we embraced telemedicine earlier here than some other places, just because of these difficulties with travel. And before I get into the talk, I also want to just introduce terms that I'll use and the rationale for them. So first of all, when I'm talking about the indigenous people of Alaska, I will use the term Alaska Native people. This is really the preference of our tribal leaders in Alaska. And the word people is emphasized to remember that we're talking about people and not research subjects or anything else. When I talk about the combined US populations, I will use the term American Indian and Alaska Native, and that can be abbreviated AIAN. This is sort of the official government terminology, and others may use the term Native American, especially those in the lower 48. But in Alaska, that term is not used so much, so I will stick with American Indian and Alaska Native. And then finally, when I'm talking about populations that cross the border between especially US and Canada, I will use the term Indigenous North American populations. Just what I'll talk about today is I'll start out with some context about the Alaska Native population and healthcare delivery, including our rheumatology field clinics. I'll then talk about research and focus in on RA and lupus, where we really have the most data. I'll talk about some future directions, both ongoing and potential, and then also highlight kind of opportunities for collaboration. So in the research and the clinical setting, I work for an organization called the Alaska Native Tribal Health Consortium. It's a statewide tribal health organization that provides medical and other services to Alaska Native people throughout the state. These include community health service, health research, telehealth support, and even things like rural water and sanitation system construction. It's the largest tribal health organization in the largest state, area-wise. The map on the right shows the indigenous language regions of Alaska, and related regions of Canada and Russia are also shown. There are in the state about 180,000 Alaska Native people, and about 30% live in the region kind of around Anchorage. The rest reside in about 200 communities throughout the state. Most are not on the road system, and most are very small. Only 3 have a population of more than 10,000. Traditional foods from the land are an important part of the lifestyle, and it's important to know about the seasons for these as we plan clinic travel. In different regions, this may include marine mammals, fish, game meat, berries, and plants from the land or sea. When I came to Alaska in the early 2000s, there had been some NIH cooperative studies that had documented a high prevalence of rheumatoid arthritis and spondyloarthritis in the Alaska Native population, including a very high prevalence of HLA-B27 positivity of up to 40% in some parts of Alaska. And then there had been a smaller study showing high rates of lupus as well. And we'll go into all these in a little bit more detail later. As Alaskans, this is one of our favorite versions of the map, with the actual size of Alaska superimposed on the lower 48 states. Most US maps put Alaska and Hawaii off to the side and not to scale. So this gives you a better picture of the sheer area of our state. Our hospital in Anchorage is shown in the middle, right here, and is approximately located in the state of Missouri on this map. A few examples of the places where we travel include Utqiagvik up here, which is formerly called Barrow, and it's about 800 miles by air on a jet, and it's located in northern Minnesota on this map. On the bottom right is Metlakatla, the farthest southeast community that we go to. And that one is also approximately 800 miles on a jet to Ketchikan, with 2 stops along the way, and then either a ferry or a float plane over to Metlakatla. So just showing you the vastness of this place, you can imagine that the healthcare delivery system really needs to be somewhat different than what is available in a big city. So I'll talk about the healthcare delivery system. I mentioned that the Alaska Native Tribal Health Consortium is a statewide tribal health organization. And then we have what's called the Alaska Tribal Health System, which is an affiliation of both the statewide organization as well as some regional tribal health organizations who provide primary care at the village or hospital level at the smaller communities. And I want to make sure to distinguish, so most of you are familiar with Indian Health Service. In Alaska, all Indian Health Service funding since 1997 is managed by tribes under what's called a compact agreement. So this allows for tribal self-governance and management of the healthcare system. So this is Indian Health Service, but it's really not, because it's very different when it's not federally managed. And then I mentioned that primary care is managed by the regional organizations, and the really small clinics are kind of the ones that are pointed to in red on this map. The medium-sized clinics are the ones with the green lines. The larger clinics with MDs have yellow, and then the hospitals, including some smaller regional hospitals, have the blue lines here. And then our tribal health organization provides specialty care statewide in a variety of formats that I'll talk about next. The Alaska Native Medical Center is in Anchorage, and it's the tertiary hospital for the Alaska Tribal Health System. The photo on the left is how it looks, not all year long, but certainly in the summer. And then on the right is the lobby area right inside the hospital. Before the COVID pandemic, it was a really popular gathering spot for people who had to come in for care from other parts of the state. And hopefully it will get back to that again. Our rheumatology specialty clinic is on this campus, but in a different building. And we do have most specialties available in this hospital. In some cases, people do have to be referred to private physicians, either in Anchorage or out to Seattle or a lower facility in the lower 48 for very specialized care. For rheumatology, like other specialties in this tribal health system, we provide care at the hospital in Anchorage, as I mentioned, as well as traveling to multiple rural field clinics in hub communities, which are shown in green on this map. This year, we're doing a total of 32 trips per year to field clinics. Each of these ranges from about 2 to 4 days. And as Dr. Gardner mentioned, I've been to a lot of these places. I'll do 10 trips this year. So we share these between different rheumatologists, and the total number of clinic days and locations has been somewhat the same since 1997. And I'll talk about a little bit more about these opportunities in the next slide. As you can imagine, there are many benefits of traveling out to the field clinics. For patients, it minimizes their travel burden and allows them to sort of streamline care in the same setting. For rheumatologists, I think it's really important for us to learn about local resources as well as what's available, meet the staff, meet the primary care providers, and improve relationship building as well as improve referral quality and quality of care in between our visits. And then finally, the primary care providers also express that they enjoy the relationship building, knowing how to get a hold of us, and then having some education typically while we're there, whether it's formally as a didactic lecture or informally with consults, curbsides while we're there. So I'm going to move on to talk about some research, and I'll talk about the two conditions where we really have the most data, which is RA and lupus. And the photo on this slide is actually a patient that Dr. Gardner met years ago. She had polyarticular rheumatoid factor positive JIA as a very young teenager that persisted into adulthood with severe deformities. She enjoyed beading and was still able to function well enough, and kindly shared these photos with us to use in presentations. So I'll start by talking about rheumatoid arthritis. And when I came in the early 2000s, there was a lot that we already knew about rheumatoid arthritis in indigenous North American populations, thanks to some pioneering work by different groups, including Bob Wilkins in your area. And there were several studies of the prevalence of RA in different tribes as compared to the general US population. The publications listed tribes by name, but because the contemporary practice is not to name a tribe without explicit permission, I've just listed the US state where the study was done in this figure. And these studies were published from the 1970s to 1990s when there was a lot of interest in this area. On the left is just sort of showing the general US population in a contemporary time period, and then the different tribes and the overall prevalence in blue, women in orange, and men in gray. And there were some similar findings in Canadian First Nations populations. And as you can see, there are some variations in prevalence, but overall the range was 2 to 10 times higher in these different tribes compared to studies in the US general population. And unlike lupus, which has a high prevalence in other minority populations, rheumatoid arthritis is only high in American Indian and Alaska Native or Canadian First Nation people, and not in other minority groups. So it seems to be somewhat different regarding the mechanism. In addition to having data on the epidemiology in the early 2000s, we knew that RA was more severe in Indigenous North American populations. Some of this data was from those early studies on this slide, and then some is from Christine Peshkin, a publication in 2010 from Manitoba. But features include suggesting more severe disease included early age of onset, more frequent erosions. The early studies showed high prevalence of both rheumatoid factor and ANA positivity. And then more recent studies have shown that the prevalence of anti-citrullonated peptide antibodies are also higher. Extra-articular involvement, more large joint involvement, and higher inflammatory markers have been described. This functional status was from the Peshkin paper. There was an earlier paper in Alaska that suggested that people were reporting a better functional status than expected, and actually might have been underestimating their disability or not complaining as much. So that's may differ in different populations. Because this was the Indigenous North American populations were the only populations with high rates of RA, genetic factors were thought to be pretty important. And there was a lot of excitement at this time, again, right in the early 1990s is when a lot of this work was done with the shared epitope hypothesis. Several studies looked at HLA alleles associated with RA in the same populations that have been studied with respect to prevalence. And they found a high prevalence of what they initially called DR14, and then later found was predominantly DRB1 1402. And the figure on the right shows the prevalence of DR14 in cases with RA compared to controls. So the cases are in blue, controls are in orange in 3 different populations. So as you can see, there was a very high prevalence in the controls as well as the cases. And when a meta-analysis was published in 1995, combining data from these 3 studies and found an association between HLA, DRB1, 1402, and RA with an odds ratio of 2.63. So in the early 2000s, when I started working up in Alaska, the big questions were sort of still, why? Is it all genetic or is there something else? Why is RA more common in Indigenous North American populations? Also, why is it more severe? And the reasons for these 2 could be similar in some cases, but they might be different. And then furthermore, what interventions might be useful to improve health outcomes? And should we be focusing on preventing the onset versus other later things to improve the outcomes? And I'll talk about several different aspects of research related to these questions. So this is my simplistic version of a diagram you've seen many times, looking at the path to development of RA and the focus on preclinical studies. So I kind of showed genetic and environmental factors, and I put cigarettes in there as a big environmental factor, leading to the development of autoantibodies without symptoms, which then leads to early symptoms, and then to a diagnosis of RA. You'll see other diagrams with more information and with the arrows potentially going back the other direction as well. But when I was in fellowship in Colorado, I had the opportunity to work on the very early days of the SERA studies of the etiology of rheumatoid arthritis, which was led by Mike Hollers and Jill Norris, and include partners at Virginia Mason as well. And then after moving to Alaska, I worked on some genetic work with Lee Nelson. And then she introduced me to Dr. Hani El-Gabalawi, who had an interest in this preclinical RA, but specifically focused on Canadian First Nations populations. And so I was able to work together with Dr. El Gabalawi and his team with his funding through the Canadian Institutes of Health Research. And we recruited first-degree relatives of people in Alaska Native people with RA, and we did a baseline evaluation of joint symptoms, autoantibodies, environmental exposures, and genetic factors, and then followed people over time to see if they developed symptoms. This photo shows our team in a small community in Southeast Alaska where we did a lot of the study recruitment. And one big challenge for this work was that this is a community that requires a long travel journey. We were collecting biospecimens and data while we were there and transporting everything back to Anchorage to process, freeze, test, or ship to Canada. The study continued for about 10 years total in Alaska and recently ended, although the Canadian group is now working on a prevention study. I'll give a couple brief highlights of some of the data from the study. And so here is a graph that shows the incidence of inflammatory arthritis based on autoantibody status at baseline in this cohort, with blue being rheumatoid factor and CCP negative, red being rheumatoid factor only, green CCP only, and purple both positive. And this is very similar to what you might expect based on some other studies in Europe and the US, that the incidence increased with more autoantibody positivity and especially the citrullinated antibodies. But the incidence of RA for these groups was somewhat higher than you might expect, consistent with what we knew about the high prevalence and incidence of RA in Indigenous North American populations. And then I'll briefly come back to HLA-DRB1 1402. So I mentioned that as the shared epitope allele that seemed to be associated with RA in this population. There was a publication that came out in 2012 that suggested that 1402 may not preferentially bind citrullinated peptide in the same way as other shared epitope alleles because it had a serine in position 13. So after that, we some work with this cohort found that, again, 1402 was associated with RA in this cohort, and the odds ratio was similar to that previous meta-analysis of 2.5. But the mechanism appeared to be somewhat different than other shared epitope alleles, although it still involved the way in which citrullinated peptides were presented. So I'm going to switch from genetic work to a little bit more about sort of quality of care and access to care, because I talked about how several aspects of the severity of RA in Indigenous North American populations suggest that genetic factors play a role, but such as the young age of onset, but many aspects of the severity of RA really depend on access to DMARDs, especially early in the disease, which also depends on access to rheumatologists. So I initially started this project years ago focused on quality of care, looking at the Alaska Native Medical Center from 2005 to 2008. And overall, we found that many of the recommended aspects of care were performed a high proportion of the time, although there was some variation. And seeing a rheumatologist at least once was associated with higher performance, which was very similar to some of the other quality studies coming out around that time. The mean number of rheumatology visits in 5 years was only 4.8, so about 1 visit a year. So there was still room for improvement, but there was still some benefit from seeing a rheumatologist at least that often. So we didn't think it was only about quality of care, but we certainly thought that was an important component. And then thinking about more recently improving the health of Alaska Native people with RA and the travel that we talked about, we began using synchronous telemedicine around 2015. And so I developed a research project to evaluate that. This was funded by ARC as an R21. At the time of the study design in 2016, we used telemedicine as described in this slide. So it was all clinic to clinic because individual homes in the rural communities did not have the bandwidth to do direct to patient. There were presenters there, but they weren't formally trained in joint exam because there were so many remote sites. As I mentioned, there's 200 communities throughout the state. We used it in the follow-up phase of care. We would schedule it in the middle of a regular clinic day and alternate in person and video. And we tended, we tried not to use it for every visit. So we would try to see people in person at field clinic or in the hospital when possible. And all this has changed after COVID, but when the study was designed, this is what we were doing. So as I mentioned, we had an R21 study. It was designed in the setting of usual care. We could not do a randomized controlled trial, but we were looking at the impact of telemedicine, rheumatology follow-up on outcomes and quality of care. And the timeframe was 2016 to 2019. So the factors associated with use of telemedicine probably are not surprising to anyone. People that had higher disease activity, people who were seeing a rheumatologist who used telemedicine more often, people who had more positive perceptions of telemedicine based on a survey, and then a higher number of rheumatology visits in the past year. We also looked at outcomes and quality of care over just a 1-year timeframe because this was a short study. And we found that the RAPID-3, although it was higher in the telemedicine group at baseline, it really didn't improve over time, and the difference between the two groups persisted at 1 year. Quality measures looked about the same in both groups, except for less disease activity documentation in the telemedicine group. And again, this was the early days of telemedicine, and this could have changed since then. We currently have a larger grant from ARC looking at a broader set of chronic diseases and specialty care, but we do have some specific measures of RA. And we're looking at predictors of telemedicine use, outcomes, both general and disease specific, especially for RA, and then a cost analysis. And this started in April 2019, so we're lucky enough to get some data collection prior to COVID, and now we are actually able to do some additional data collection since things have changed a bit. But I want to share just a couple. We had some qualitative studies as part of the predictors part, and I wanted to share just a couple of quotes because I think these were some key themes that we heard that are now coming out in the literature as well. A patient mentioned the lack of reliable internet capabilities in the villages, and you're hearing lots of publications about digital equity. Now that telemedicine is being used more widely, everybody's realizing that this is an issue. Another patient just mentions the burden of travel, not just with respect to cost, but also they mentioned emotionally draining, others mentioned physically draining to travel. And so that's a benefit. And then a provider mentioned how they prefer to use it in the follow-up phase of care because it's hard to meet someone and develop rapport over video. So these themes kind of fit with a lot of the things we're hearing now in other communities as well. So next I'm going to switch into the epidemiology of another condition, which is lupus. And I got involved in this area around 2009. I mentioned to you earlier that we had some evidence that lupus prevalence was high in some indigenous North American populations, but as this slide summarizes, there were some limitations to existing data on the epidemiology of lupus by race and ethnicity in the US, and the CDC had taken an interest in this and funded population-based lupus registries to determine the incidence and prevalence of lupus by race and ethnicity in the US in different populations, but using standardized data elements and methods across the sites. So ultimately, the CDC funded 5 registries as summarized in this slide. 2 sites were earlier, including Michigan and Georgia, and then 3 additional sites were funded in 2010. And the Indian Health Service site was the one that I led, which I'll show you a little bit more about that in the next slide. So Indian Health Service has 12 administrative areas, but we included just 3 of those: the Alaska area, the majority of the Phoenix area, and part of the Oklahoma City area. As these were areas where Indian Health Service or tribal facilities actually had rheumatologists practicing there. Since that time, there's actually a few others as well, but at that time, those were the only areas where they had Indian Health Service direct rheumatologists, and the Oklahoma one was newer than the others as well. So the first 2 registries, Georgia and Michigan, had a little bit of an earlier time frame, but our time frame for prevalence and incidence was the same as California and Manhattan. So prevalence in 2007, incidence 2007 to 2009, and we were using similar methods to the other registries. Our denominator was the IHS, what we call the active clinical population in those years, which required people to have 2 or more visits to an IHS or tribal clinic in the past 3 years, and at least 1 to a core medical clinic. And they had to reside in a community of interest for the registry, which I talked about already. Well, I call it Indian Health Service. I mentioned to you that Alaska it's a compact and tribes are managing it, whereas in Phoenix and Oklahoma City, the ones that we included were federal Indian Health Service sites. This slide shows our main results with respect to the prevalence of lupus in 2007. And the overall age-adjusted prevalence was 178 per 100,000, as shown in the middle box, highlighted in red. And then the prevalence in women was 271 per 100,000. In men, it was 54 per 100,000, and it was highest in the Phoenix area, although all areas were high. Our primary definition of lupus was meeting 4 of the 11 ACR criteria, based on the time that the study was designed. That was the standard criteria set still. And so this figure shows the ACR criteria from most common to least common, with the overall prevalence in black, and then the different regions in the different colors. So the most common, of course, were ANA and hematologic criteria. Arthritis seems slightly more common in the American Indian and Alaska Native population than other populations, and even more common in Phoenix area than others. And then renal disorder was present in about 40%, which is consistent with other minority populations, but higher than what was found in white populations. On this slide, I'm summarizing data from a publication combining all the 5 registries, and there was a meta-analysis by ethnicity and race. However, the American Indian and Alaska Native data comes only from the IHS lupus registry because none of the other registries had that. But as you can see on the top of this slide, the American Indian and Alaska Native prevalence rate was the highest, although there may be some overlap of confidence intervals with the prevalence in Black populations as well. We did a similar analysis of incidence, and these were closer together, but they were still high. It was still high in American Indian and Alaska Native people. And then the IHS registry, we pulled all cases of potential lupus from Indian Health Service facilities in these regions. And there were some that actually had a stated diagnosis without a rheumatologist diagnosis. And our chart abstractors looked in a lot of detail to try to find any rheumatology visits, including those outside of the IHS system, if the notes were available in the chart, or mention of those. And in some cases, we just couldn't find any rheumatology visit to document the diagnosis. In cases where we did not find specialist documentation of the diagnosis, people had fewer ACR criteria documented and were less likely to meet any criteria sets or all criteria sets for lupus. The figure shows, again, ACR criteria from most common to least common, with primary care in orange and specialist in blue. So you can see that the order is the same for this, especially the more common ones, but they're all somewhat less commonly documented by primary care providers. In addition to the information about diagnosis, we looked at management of lupus in people ever seen by a rheumatologist versus only seeing a primary care provider. And as expected, rheumatologists in blue here were more likely to prescribe all the different medications, and especially the ones that were more immunosuppressive. And people ever seeing a rheumatologist were more likely to have some lupus monitoring labs ever done, such as complement and double-stranded DNA. And you're all in the lupus registry. I want to talk about one more thing, which is mixed connective tissue disease. And of course, you're all familiar with the diagnosis of MCTD and the manifestations. I know that some rheumatologists will argue about whether or not this is an actual disease, and I'm in the camp that believe that strongly that it is. We think it's less common than lupus, but there were very few reports of the epidemiology. So in our lupus registry for IHS, we included data elements that were necessary to define mixed connective tissue disease. And this was because of the clinical impression of rheumatologists, both in Alaska as well in the Phoenix area, that suggested that there might be more mixed connective tissue disease in the American Indian Alaska Native population than in other populations. We did determine the age-adjusted prevalence of mixed connective tissue disease to be 6.4 per 100,000. There were very few comparator studies, but there was one in Norway that showed 3.8 per 100,000. So maybe it's a little bit more common in these populations. However, the overall lupus prevalence, if you remember, was 178 per 100,000. So this is much less common than lupus. In the next few slides, I'll talk about an ongoing study as well as potential future directions. And this is our campus with the hospital on the right and the primary care clinic on the left. I talked a lot about the epidemiology of different rheumatic diseases. And I wanted to mention that I have an ongoing NIH study funded by National Institute of Minority Health and Health Disparities, where we are looking at several aims, but the one I wanted to highlight is aim 1, where we are looking at the prevalence of specific forms of arthritis and autoimmune diseases in Alaska Native people statewide and in a more contemporary time frame. So you'll see on the right, some of the conditions we're looking at, like rheumatoid arthritis and spondyloarthritis, have been studied before, whereas some have not, like the last number 5 through 8, Sjogren's, scleroderma, myositis, and vasculitis. So we're looking forward to having some data about those fairly soon. I mentioned that the prevalence of HLA-B27 and spondyloarthritis were high in the Alaska Native population and based on older studies. And this is summarizing those older studies. On the left is the prevalence of HLA-B27, and on the right is the prevalence of what was called spondyloarthropathy at that time. On blue is just the general US population for comparison. In orange is Southeast Alaska, and in gray is Western and Northern Alaska. And as you can see, the prevalence of HLA-B27 goes up, as does this prevalence of spondyloarthropathy in those different populations. And as I mentioned, our current study will include spondyloarthritis with more contemporary definitions, and we will also be looking at psoriatic arthritis as well. And then I just want to mention gout. So of course, you're all familiar with the fact that the prevalence of elevated serum uric acid and gout in the US are rising, associated with diet and lifestyle changes. On the right-hand side, this shows you just some data about the New Zealand Maori population, which has been reported to have a high prevalence of gout. And I show that just to say that in contrast to that, there's been a low prevalence of gout reported in a couple small studies, including one of the Alaska Native population around the time those other studies were being done in the 80s or so. And then one more recently in the First Nations population of Alberta by Cheryl Barnaby and her group. And so if we are looking to confirm whether the prevalence of gout really is low, and if so, that could lead to some interesting future studies. So I talked about, when I think about future work, I'm really most interested in how can we improve outcomes in rheumatic disease in American Indian and Alaska Native populations. While there are some prevention studies ongoing, especially for RA on the left, I think the biggest bang for our buck in the near term is more on the right-hand side of the slide, the other 3 boxes with recognizing symptoms, getting to a physician who recognizes the potential diagnosis, refers a patient to a rheumatologist, early access to rheumatology, early access to DMARDs or whatever medications are needed, and then long-term retention and care and access to medications. So while prevention is definitely an area of interest and study in some groups, I would be more interested in future studies focused on the other 3 here. And this is a map that I've shown in other presentations in the past, but on the left is just the ACR workforce study that you're all familiar with. This is their diagram from 2013 showing the number of rheumatologists per capita, and the black are the areas with the high number of rheumatologists, and so per population. And so you can see, of course, the East Coast and especially Boston has high numbers of rheumatologists. On the right is just some census data from 2010 showing the areas where the highest number of American Indian and Alaska Native people live, with blue being, dark blue being the most. And as you can see, these are sort of almost the opposite of where the rheumatologists are. And, there have been some improvements. There are some rheumatologists going into areas where American Indian and Alaska Native people live, but there's still definitely a significant gap. In addition to access to rheumatologists, there's other important factors to improve health. These include access to care and other specialists, but also culturally informed care, so people feel comfortable bringing up new symptoms for evaluation. Dr. Cheryl Barnaby, who I mentioned, has done some interesting work in Alberta about people not feeling like they could bring things to their doctor in some cases. So that's an important aspect. The other thing is there's been a big interest in telemedicine, and it's been touted as something that could increase, access to care and improve the workforce, not so much shortage, but maldistribution. But I think one of the most interesting areas now in the telemedicine research is kind of when is it really appropriate and when is it not. I talked about linkage to care. As far as clinical trials, this is a big area, not so much my area, but there is very little clinical trial data relevant to American Indian and Alaska Native populations, very low enrollment in clinical trials, and some of the ways, there's a lot of interest now in trying to increase clinical trial participation, but some of the barriers may be somewhat different and need to be addressed specifically. And then if we're not going to have patients seeing rheumatologists as often, are there other ways we can get education about the disease and the existing diagnosis to patients and their families, as well as education for primary care providers to have them help with the ongoing management of these existing diseases. And before I wrap up the talk, I do want to just spend briefly speak to research ethics when working with Indigenous populations. It was kind of different for me coming from a university training up to Alaska and finding out that things are different. Things are slower as far as the approval processes and things like that. And at first it was frustrating, but really, there are very good reasons for it. And as I learned to be more invested in this and the reasons behind it, I became more comfortable with it. But you're all familiar with the fact that you go through Institutional Review Board or IRB review to look at the federal regulations governing research. And in Alaska, we have a separate tribal review process that comes after IRB. And so that adds some time to your project. And then community engagement is a really important piece of the research that actually can come before, during, after, and then we do get approval for publications as well, a community review or tribal review of publications before they go out. So it's different. It's not going to be fast, but you can definitely learn to work with it and do really high quality research within this system. In addition to rheumatology specific research and clinical care, I've been involved in some work to build research capacity in the Alaska Native population. And we have a grant through this NIH program called NARCH, Native American Research Centers for Health. I'm currently the PI for the center grant, and one of the projects in it is this program called the Alaska Indigenous Research Program, which was developed to train people in research from beginners to intermediate to advanced people, but to train them in research specifically with the Alaska Native or other Indigenous populations. And the target audience for some of this is Western researchers to figure out how to do more ethical research, as well as introductory researchers, typically more people from the community wanting to get them involved in research. We started in 2019, and the photo on the right is from that in-person training at the blanket toss. And this woman in the picture actually ended up doing an internship with us the next summer. This program was just funded for another 4 years, so we're excited about that. And then we don't get very many opportunities to train and mentor people here in Alaska compared to what you get in Seattle, but when we do, we love them. And so I just highlight a couple of these. The top one is actually a medical student that worked with me and Ann Stevens on JIA prevalence, and I'll tell you just briefly a little bit more about that in the next slide. And the bottom one is the fellow that Dr. Gardner mentioned, Joanna Marco, who came and rotated with us for 1 month in 2019. And she did a clinical and research rotation. And this is her poster from the ACR on the bottom here. And so just quickly about juvenile idiopathic arthritis, we had thought that there was probably a higher prevalence in American Indian and Alaska Native children based on some studies in previous populations. So we did a study looking at the prevalence statewide in Alaska Native people, and we found the prevalence 91 per 100,000, which was slightly higher than what had been reported in a recent Olmsted County, Minnesota study. The distribution of subtypes was a little bit different, and in the right here, this gray bar is enthesitis related arthritis as a proportion of all JIA cases in Alaska Native kids. And here's the gray bar for Olmsted County. So enthesitis related arthritis was really overrepresented, and that was the biggest finding here. And that shouldn't surprise you because I told you that the HLA B27 prevalence is very high in the population. And then I mentioned we do some sort of community engagement in all of our research to some extent, but sometimes it's more fun than others. And so Dr. Stevens and I got to go to Camp Arctic, which is a camp for kids with JIA and their families on the Kenai Peninsula in Alaska. And during the camp, which includes some fun activities as shown in the middle, we presented this infographic and went over this with parents during one of the sessions about our study results. So I want to wrap up just by showing you the vision of ANTHC, which is that Alaska Native people are the healthiest people in the world, and ultimately keeping that vision in mind whenever we're considering applying for a new research grant, designing a new project, or thinking about collaborating with someone has been very helpful to kind of guide our decisions and keep us focused on improving outcomes really in the more near future rather than more distant health benefits. And finally, I'd like to close by saying thank you. This is shown here in many different Alaska Native languages on the slide. Thank you first and foremost to Alaska Native people who have taught me so much, and then all the funding organizations I mentioned, including NIH, ARC, CDC, CIHR, and all the mentors and collaborators that I mentioned as well. Thank you so much for having me today.
Elizabeth, thank you so much for that wonderful discussion, and brought up some questions that you and I can talk about in our session together. We have some people who've raised their hands and some written questions. Let's go to Denise Craswell first. She has her hand raised. Denise, you want to ask a question of Elizabeth? Need to unmute. Or do I unmute you? I don't think I unmute you, do I? Yeah, Denise, if you want to ask a question, go ahead and unmute yourself. You're still muted. Maybe move on to Maddie. You have a question for Elizabeth? Huh. Sorry, I'm not sure. Maybe Danielle can see how we can unmute you. Let's go to the written questions then, and maybe we'll come back to the people with. Gordon Starkeybaum asks, Elizabeth, do you have a relationship with the VA patients in Alaska?
We do see some VA patients, yes, at the Alaska Native Medical Center. That has varied over the years. And I'm in clinic less than some of the other rheumatologists, but yes, we still definitely do see them. Yes.
Gordon also asks, do the primary care providers in the area that you travel to, are they becoming experts in, or not expert, or comfortable using medications that we prescribe, such as biologics?
Yeah, so I think as a general rule, yes, and it sort of depends on how long they've been practicing there and the extent of interaction they've had over the years. But certainly, especially some of the really well-established providers in areas where we've been coming for a long time. Yes, some of them are very comfortable actually, starting methotrexate, monitoring hydroxychloroquine, and then some even with some of the biologics, especially TNF inhibitors. Of course, they'll always check with us. But yeah, some of them are, especially if they've been there longer.
Namrata Singh asks, well, thanks you for the wonderful presentation, and wants to if you have any comments about pregnancy outcomes in American Indian, Alaska Native women with rheumatic diseases.
That has not been studied that I am aware of, so I don't have a comment on that from a research standpoint. And I don't want to really guess. Yeah.
There's a potential collaboration there.
Right, exactly.
And Ann Stevens, who's with us, also says, thank you. You mentioned underestimation of functional status of patients with RA. What are your thoughts about obtaining more comparable self-reported function in research studies, given the cultural traditional barriers?
I think that's a really challenging area. Absolutely. Thanks for bringing that up. And even I think this is an area where we need more research. I mean, I mentioned those 2 studies, which were quite old. We haven't done that again, more qualitative research about what do people think it means when they give you their patient global of whatever. I typically, like in the clinic setting, I'll actually explain what that means in the form, because sometimes I'm not sure people even understand it. So maybe there's a health literacy area as well with that. But yeah, I think that's a really important area of study, like how accurate are these disease activity scores that we think are validated in other populations. So more to come, hopefully, in that area.
Curtis Archibald asks, how are we doing in terms of recruiting Native Americans to become healthcare providers?
We could do better, but this year, there was actually just a story I read this week. There are 3 Alaska Native women in the first year Alaska WWAMI class right now. So, but that's the highest number of Alaska Native medical students they've ever had. And it's still not enough. But those students are doing actually amazing work. They're going out and speaking to kids in the high schools, mostly remote, virtually, but yeah, they're trying to get kids interested in medicine. There are a variety of programs that are working on that. But yeah, there's definitely more needed, and they're very underrepresented in medicine.
Anne has another comment, thoughts. What are your thoughts about a pathway forward in identifying modifiable risk factors? Dietary, microbiome related factors are obvious candidates, but famously difficult to obtain data and samples. Would serology be possible for candidate antimicrobial antibodies or other biomarkers?
Well, I mentioned I've sort of gotten a little bit away from that area myself, so that might be. I know that certainly the Sierra group and the Hanny's group, and in fact, actually, they're going to be talking about this at the Great Debate at ACR coming up this week, with respect to RA. But they're identifying some different candidate associations with the microbiome. But yeah, I think one of the challenges that Anne and I ran into actually is that we are talking about a very small population here. And we're talking about a population, if we want people with incident disease or preclinical disease, it's even harder to identify a large enough group of people to really study some of these factors, which is sort of why I've gone to focusing more on how do we just improve outcomes of people with existing disease. But it's still an important area to study.
Yeah, something I want to talk to you about when we meet at 11:30 is how ancient is rheumatoid arthritis among this group. My own bias is that it may be more recent, and it might be when dietary changes were made for European diets were introduced to American Indians, went away from traditional diets, and I don't know. You and I can talk about it. Maybe a way we can see if we can figure out how to ask that question.
Yeah, it's an interesting question. And, the HLA DRB 11402, there's been some thought about, where did that come from and why is it there? And was it potentially protective against certain other infections, similarly to how B27 has been thought to be protective. So yeah, lots of interesting questions. I'm not sure we have all the answers.
Mark Wenner asks, Liz, thank you for a wonderful talk. Are there genetic factors other than HLA that might suggest genetic contributions to higher risk?
So this hasn't been studied very much in these populations. There have been a few studies in Canada with a few other genetic associations. But those genetic studies sort of, it's an interesting story that again, would take a while to go into, but there's a lot of concerns about genetic research in Indigenous populations. And so there was a lot done kind of early on, and then there was kind of a stop. And there's a lot less genetic research in these populations now. Although there's a resurgence of interest, and there are some Native American geneticists trying to get people more involved in these studies, but we don't have all that information, basically, is the short answer.
Thank you. So Brianna Montilla asks, is there any research comparing outcomes of Alaska Native peoples living in Alaska to those living in the contiguous 48? How might these populations differ in your mind?
Not research that I can think of specific to our diseases. There's research in other diseases per se, like diabetes. But certainly, yeah, there are a lot of differences. Alaska is very different. The way that we don't have reservations, except for one, which we have the Alaska Native Claims Settlement Act. So there's a variety of, financial situation is different. The land is different, the foods are different, the types of activities are different, and then the exposures are different. So yeah, there are many differences. So I'd expect to see some commonalities and then some differences as well.
Phil Meese asks, curious if your PSA patients have more axial PSA involvement, partly related to the higher HLA-B27 status than the usual 40% we see in our populations.
So that's one that's never been studied in our population. We are just working on it now and collecting data, so I don't have an answer, but from a clinical guess, I would say that I don't think it's more than 40% axial involvement, but yeah, like I said, no research data to support that claim yet.
See, Maddie Piero asks, are there data showing any influence on diet or on inflammation or inflammatory arthritis in American Indian Alaskan Natives?
No specific data on people with existing disease, or actually even in the development of disease. There's an interesting story. Alaska Native people have one of the highest rates of omega-3 fatty acid consumption in some areas of the state. And some of the other studies of preclinical RA are showing that people with higher levels of omega-3 fatty acid consumption had lower rates of preclinical autoantibodies. So, but that sort of it goes against what we're seeing in the population. But in an individual, once somebody has established disease, might that be protective? Yes, and maybe it's outweighed by some other factor with respect to severity. But no, as far as actual research data on that question, we don't have that.
Mark Wenner asked a really interesting question. Are there traditional treatments that are common in Alaska Native populations that have caught your attention?
So actually, we did propose a study. I was working with a chemistry professor that was interested in Devil's Club. And we proposed a study of that a few years back to NIH, and it was not funded, and we didn't pursue it further. But yeah, Devil's Club is Southeast Alaska, kind of very common remedy for a variety of different things that can be topically or ingested. And so that was one that I think might be very interesting to look into more.
Maddie Piero also asks, since she's a Canadian, have you seen, not sure she asked a question because Canadian, but she is from Canada. Have you seen differences in healthcare access for Alaska Natives compared to Canadian First Nations? Has this translated into different outcomes?
So the systems are very different, and I learned a lot about that, working with Haniel Gabalawi in that group in Manitoba. As to like comparative studies, we haven't done that. But yeah, absolutely, there are differences, and I would expect that it would translate to differences in outcomes.
And we'll do one last one. Gordon asks, is there any interaction between HLA-B27 and DR beta 1 1401? Or do you mean 1402, Gordon?
Interaction, not that I'm aware of, but I'm not sure that anybody's, I mean, we definitely do see some patients who clearly have RA and spondyloarthritis. And you think about that, those two shouldn't coexist, but because both of those genetic markers are more common in the population, maybe it's just more likely to happen. But as far as any kind of like interaction in population prevalence or otherwise, I'm not aware of any.
I've always found it interesting that the Clinkets have high rates of rheumatoid arthritis, and their neighbors, the Haida, tend to have more spondyloarthropathy, and they're sort of contiguous populations there. It's just sort of interesting. We actually did have a patient in a hospital several years ago who was, I think, mother was Haida, dad was Clinket, and he had both rheumatoid arthritis and ankylosing spondylitis.
Yeah. Mm-hmm.
All right, Elizabeth, thank you so much for taking your time to meet with us. And